Welcome to Medical Matters Weekly with Dr. Trey Dobson, presented by Southwestern Vermont Healthcare and Catamount Access Television.
Welcome, everyone. Today is June 13th, 2022. We are recording a show for our June 15th episode. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth Health. This is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. And my guest today is Dr. Matt Vernon, who is a radiation oncologist. He's the medical director of Southwestern Vermont Regional Cancer Center, and he happens to be an avid adventurer and road racer. So we'll talk to him about oncology and everything running and trail running and go through the next 30 minutes. So Matt, welcome.
Howdy.
So Matt, how long have you been here in Bennington, Vermont?
So coming up next month, I think it'll be 9 years since I started in 2013.
That's great. So Matt, Dr. Vernon received his medical degree at the Medical College of Wisconsin in 2008, completed residency in the Department of Therapeutic Radiology at the University of Minnesota in 2013. He's, of course, certified by the American Board of Radiology, and he's really been instrumental in bringing important cancer treatment technology to SVMC. Almost every year, we get an update in the technology. And Matt, I would say that SVMC, as in its partnership with Dartmouth Health, really has some of the most cutting-edge technology that's out there and available.
Yeah, that's true. I mean, to the degree, at least, that it's appropriate for a clinic our size, certainly we have basically everything in the cutting edge as it goes in the radiation field. Every once in a while, I'd say, less than 1% of patients that are referred, I'll determine, this is really something that would be better off handled in another place, but almost everything that can be done up in Dartmouth and larger sites we can treat here.
Right. You and I have talked about before some really rare cancers that may undergo, special type of research type treatment that may go elsewhere. But most cancers that we do that require radiation, you handle here in our cancer center.
That's correct. I mean, certainly the most common stuff nationwide is the common stuff that we see. We treat a lot of breast cancer, prostate, lung, head and neck cancers, rectal cancers, pancreatic cancer, esophagus. It's really just some of the stranger things. Pediatrics, certainly we don't treat here. Some gynecologic cancers, we can only sort of do the first phase of treatment here and then send folks out for one other type of treatment elsewhere. But yeah, it is the vast majority of things that we're covering here in person.
That's great. We'll go into that in just a minute. Let me just go back, and I was the one that led us down that path, but let me just go back and ask you a little bit about you personally. So tell us a little bit about where you're from, how you got into medicine, and then how you ended up here in Southwestern Vermont.
Sure. I mean, I grew up out west, mostly in the Denver area, sort of moved overall gradually farther east with every step of the way. As you mentioned, I went to med school in Wisconsin, residency in Minnesota, and then joined right out of residency here. I decided pretty late to go into medicine. My original plan was to get a PhD in chemistry with sort of a focus in physical chemistry. And if I had to pin down the decision, I recall actually pretty vividly going to a research conference once with a bunch of these old lifelong physical chemists that were, just passionately discussing their focus of research and talking about, the vibrational energy changes of colliding molecules. And I just, while I super value and recognize the value of basic research like that, I just didn't feel like I was going to be able to be passionate about the vibrational energy states of colliding molecules. I really wanted to be closer to where I could see my work kind of providing a direct benefit to the lives of real people. And so that was when I decided to go to med school. Radiation oncology is kind of one of the more obscure specialties that not a lot of people get exposure to in med school. I happen to know another resident there who was in radiation oncology at the program. And so it caught my interest. It's also as I'd had more of a background in physics, certainly more so than any other medical specialty. I use physics a lot more than most physicians do. And so kind of all of those reasons, as well as having some members of my family, like most people, who had been affected by cancer, that really just kind of drew my attention, at least to the point that I looked into it, and I liked what I found.
So tell me, that's a good background there. So tell me, when you think about radiation oncology, a lot of folks, you're right, they have either themselves been through cancer treatment or they have close family members that do. And so they kind of understand what chemotherapy, radiation, and other types of treatment are for and what's involved. But some people have really no idea. In fact, they think you are a radiologist rather than a radiation oncologist. So just give us a bit about, real basic on what radiation oncology is and how it treats cancer.
Sure. Yeah. So radiation oncology is simply the use of targeted radiation in the treatment of certain cancers, and actually a handful of benign conditions that occasionally we'll treat that are non-cancerous. It hits normal tissues and cancer tissues fairly indiscriminately. I say fairly because we do have a way of focusing it just kind of where it's most needed, but there's always some normal organs that are nearby that get some of the dose. But fortunately, normal tissues are pretty good at repairing radiation damage after it happens, whereas cancer tissues are not good at repairing genetic damage. That's why they became cancerous in the first place. And so there's sort of a differential effect between the radiation damage being repaired by the normal organs and not being repaired by the cancer tissues. It still doesn't kill those cancer cells outright, actually. It damages their DNA enough to where they can't replicate, but they don't actually die off until they attempt to do so. So the tumor gradually will start shrinking. It's in the oncology world, I guess I would say that it's a little bit more akin almost to surgery than it is to chemotherapy, because it's targeted. It's directed at exactly where it's needed. Doesn't work anywhere other than right where I point it, as opposed to chemotherapy that goes through the bloodstream and hits everything all at once. And so it has kind of a different role for that reason. We can target the areas at the greatest risk. Sometimes that's at the actual intact tumor, other times it's post-operatively after a tumor's been removed. Then if there are lymph node regions or other regions just nearby that have some risk of some microscopic level of cancer being left behind, then we can target those areas and leave everything else alone. Whereas, like I said, chemotherapy and other systemic therapies go throughout the entire body and really can cause side effects and other changes anywhere that they go.
So the chemotherapy, for just real basic terms, tries to target those cells that are rapidly dividing, but unfortunately affects all cells in the body to some level. And the radiation, these beams are targeted. In other words, they're narrowed down to really just try to stay on hit just the cancer cells. And they're actually synergistic for lots of treatments. Is that right?
Correct. Yeah, absolutely. For some cancers, we'll give chemo and radiation at the same time because I like your word synergy. We get kind of a 1 + 1 = 3 effect when we give them both at the same time, because the chemo makes the radiation work better. Usually it also makes the side effects more pronounced as well. And so it's got to be in the right patient and side effects that are going to be manageable and acceptable levels of risk. But yes, basically we're giving those treatments on a day-to-day basis, anywhere from 5 to 9 weeks every single day. Honestly, the worst of the side effects of radiation is how inconvenient it is, just because it's a pain in the butt to be here every day for treatment. But yes, in that way, it kind of works differently than chemotherapy. Chemotherapy tends to be any drug, like you said, that preferentially will kill off rapidly dividing tissues, but there's a lot of rapidly dividing tissues in our body, like our hair follicles and the lining of the GI tract. And so that leads to some of the side effects that people think about with chemotherapy. With the newer drugs, and especially the immunotherapy drugs, are getting better and better at exploiting differences between normal tissues and cancerous tissues. And the more that we can find things that make the cancer different, we can target just those cells, and so the side effect profiles have been getting better and better. And in the case of immunotherapy, the drug itself isn't even really attacking the cancer cells. It's just sort of cutting the brakes that normally are on our immune system as far as the intrinsic cancer fighting activity that our immune system has, so that our own native immune system can fight the cancer better. And so a lot of these cancers are really becoming much more personalized, much less kind of one size fits all. If we can do additional tests and find out what makes your cancer special, then we can give you a treatment that not only is more likely to work, but usually has a better side effect profile too.
And, so now that you've gone through that, thank you, by the way, is an excellent description. And we could just keep going with some of these discussions, and we will a little bit. But back to what you were saying initially about the travel and the fact that we at SVMC and through our DH relationship have invested in having the right equipment here. I mean, for people to have to travel 3 and 4 hours and stay overnight, that's incredibly burdensome. But they have this sort of, sometimes it's just natural to think, yes, but I want to be at a spot, at the best spot, the biggest spot. And that's not necessarily in their best interest when they can be at home, recovering at home, and receive really the same types of treatment here through you and your team.
Sure, yeah, no, and sometimes there's value in both. I never discourage people from second opinions. Sure. If patients want to be seen up at Dartmouth or elsewhere to get reassurance that what we've recommended is what other folks would be recommending for patients, that's fine. The more sets of eyes on patient cases, actually, the better the outcomes for patients too. So that's great. But what ends up happening at least 9 times out of 10 is that folks will get the second opinion, and they'll say, yes, we would do exactly what you would do. The drug is the same. Chemo is chemo, or immunotherapy. It can be administered anywhere. They'll have varying levels of expertise as far as watching for some of the toxicities and complications and so forth. But most of those drugs are pretty well established, and we can manage the drugs here. As far as the radiation goes, there are, like I was saying, there are some technological differences between different sites. But most of them are really useful in pretty rare things where it's not always necessarily going to be better to be treated on a specific machine or at a specific center. For most of the very commonplace types of cancers that we run into, the treatment's going to be exactly the same here or really anywhere.
Talk about some of the, not the details, but just the background on the advancements, because a lot of people may have experience with radiation treatment or a family member from 20, 25 years ago, and a lot's changed, particularly in limiting the side effects.
Yeah. So yeah, that's definitely true. It's a very technologically driven field, and so the technology is changing fairly commonly. To give you some perspective, our old linear accelerator, which is the machine that generates the radiation, was about 10 years old when we replaced it, and it was already becoming pretty obsolete. Our current linear accelerator is 6 years old, and fortunately does not seem to be being usurped by greater technologies quite as quickly. Most of the changes that came with our new linear accelerator had to do with imaging techniques. Basically, we can take images right on the machine with the patient in the treatment position to verify that the area that we're zapping is exactly what's been prescribed. And the better our onboard imaging is, the better our confidence that we're not going to miss the target or end up injuring a nearby organ that we want to avoid. We always put a margin of normal tissue around whatever the target is going to be, because there's always going to be some day-to-day variation in the setup. But usually that's on the order of a few millimeters. And especially if we can just snap a quick picture in the treatment setup position every single day, then we can make sure that the target is where we expect it to be, and those margins really can be quite small. So yes, absolutely. I always like to stress when folks were talking to us about the new linear accelerator that we're not giving higher doses. We could always give the same dose, but we would have been giving the dose to a larger area. We would have been involving more of the normal neighboring tissues, and so our complications and side effects were greater previously. And now that we can really zero in on just exactly where the target is with better accuracy, the amount of normal tissue getting treated is lower. So in theory, we should be curing just as many people, but with better side effect profiles, better complication and risk profiles than previously.
That's great. And like you said, it's like, sometimes it's just as much a software issue than the hardware itself, which we see in all kinds of parts of medicine. Upgrading the software and the algorithms that drive the processes is as important or more important than the actual hardware of the machine that's delivering the radiation to begin with. Walk us through a patient from day one who comes to meet you, referred to you for consideration of radiation therapy.
Yeah, so normally I'd be seeing the patient in clinic, having sort of a formal consult as you would with any other type of specialist. Once it's determined that radiation is going to be recommended, everybody would start with a mapping scan, what we call a simulation, where we use an identical table to the table that's going to be in the treatment room. We get them into the same position they'll be in, most of the time immobilizing them in some way to make that position reproducible, either with a special kind of thermal plastic that we can make masks out of if we're treating in the head and neck area, or kind of the special beanbag that we've got that we can suck the air out of and sort of create this memory foam so that we can get people into the same position each day. We'll scan them in that position and take those images to do the planning. That's where the software that you're talking about really comes through and has a chance to shine. More conventional older treatments, we would be telling the software what to do more than we are now. We would be saying, bring in the beam from this angle and give this much, and then go to this other angle and give this much. And it was what we would call a forward planning approach. For most of the patients now, the software and processing power has gotten so good that often what it makes more sense to do is actually just tell the computer what the target is, tell the computer what the organs at risk are that we want to avoid, tell them how much we're willing to give, and then the computer starts running through iterative plans, and it'll go through millions of these plans where it'll tweak something and make it better and better and better each time. And so then at the end of the day, we can be pretty sure that what the computer is spitting out is really the best that it can do. After that, we've got a number of safety checks and quality checks that have to be done. We've got a full-time physicist who works with us here in our team that takes those plans and makes sure that what the computer is predicting is going to happen is actually what the machine is going to deliver. And then the patient starts with their treatment. Once we start, they're coming in every day, typically Monday through Friday for several weeks. Usually the first couple of weeks is pretty easy. There aren't a whole lot of side effects. There's always a lag period when the side effects haven't gotten started yet. But then as more time goes on, then we start dealing with, be it what it may be, depending on where we're treating, skin reactions, GI problems, pain control, all that kind of thing.
Do people, when they meet with you the first time, I know that they're vulnerable, they're scared. What do you tell them?
Yeah, no, I mean, that's completely natural. I'd almost be more worried if people weren't frustrated and terrified. It sounds very cliche, but really kind of the best and only thing that you can do is rather than focusing on the big picture, I tell people to just kind of take it one day at a time. We can deal with today, we can deal with tomorrow, and from there, we'll take it from there. The treatment plan is never set in stone. It's always kind of tentative. And so if something becomes more difficult than people expected, or if, otherwise there are surprises, then we can always take a step back and make sure that the treatment we've prescribed on the first day is still something that makes sense. Could we take a break? Could we switch chemo? Could we reduce the chemo dose? And so it is always kind of a fluid process. And so I for this reason is why I kind of usually will tell people not to get too much of a sense right from the start exactly what things are going to look like. We'll kind of sketch that out in broad strokes, but then just take it as it comes. And just about everybody makes it through. We've got a whole palliative care team in place that helps us with side effect management, pain control. We've got a nutritionist, we've got a social worker, we've got wonderful nursing staff. Our radiation therapists are great. So it is a whole team approach, and between the whole team kind of chipping in their individual components, we tend to actually get people through it with, knock on wood, minimum of interruptions.
You have a remarkable team, Matt, which is not to take away for all the stuff you do, because you're incredible and you lead them, but you do have a remarkable team of all the staff you mentioned and some others. for really what's delivering a complex care situation. You know, all parts of medicine are complex, but perhaps oncology and cancers and radiation oncology and figuring that all out together is so difficult. And you lead them, and we appreciate it. We appreciate all the efforts they do. I know we're recruiting right now. We're trying to get in some additional oncologists, and we've also got some ideas about expanding the cancer center. Why don't you just tell the audience a little bit about your thoughts on that and what you see for the future?
Yeah, so you're correct. I mean, the shortest term goal is recruitment. Like you said, everybody's kind of hurting everywhere. Oncology is really a tough field right now to recruit for. You know, I've got theories about why that is. Probably part of it, this will sound like I'm making it up, but part of that is because we're keeping people alive so much longer. And in some cases, that's with treatment that needs to be ongoing for the rest of their life. And so the cancer population has increased because a lot more people are living with cancer for years and years. But that's definitely a priority. The new cancer center, as you mentioned, is something that we're actively raising money for and meeting weekly to sort of finalize what exactly that's going to look like. It's going to double the number of exam rooms and infusion spaces. Most of the space increase will happen on the chemo side. We did a little light renovation when the new linear accelerator went in 2016 on the radiation side, but it'll connect to the existing radiation department and then basically build an entire new building from there off into the parking lot, what's currently parking lot. More workspace for staff, just everybody sort of being a little bit more centralized where the nurses station can be, keeping a closer eye on infusion patients. So that's exciting. And finally, I guess, as far as future directions, honestly, the strengthening of our affiliation with Dartmouth is really a huge part of the near-term plan. Radiation oncology actually has perhaps been the department that's had one of the closest affiliations with DH for several years, basically stemming back to when I got here in 2013. Since then, I've been meeting weekly with all the DH radiation oncologists. I get a chance to present all my new cases and you know, in turn see the cases being treated in not just Lebanon but also St. Johnsbury and Keene. So I've always got 9 more sets of eyes looking at all my cases, and I can in turn see what they're doing. Most of those cases, you know, 95% of them are probably pretty routine. But especially for that other 5%, every once in a while, more unusual case comes along where it just makes more sense to sort of tap into the intellectual capital that we get from our affiliation with Dartmouth. And so I think as we strengthen our affiliation with Dartmouth institution-wide, we're going to see more departments sort of have that same level of benefit, hopefully, as well as being able to better share staff and resources and so forth with Dartmouth. So no, I mean, I envision us becoming really, truly more of an extension of the Lebanon mothership and really part of the organization. But as you were getting to before, much closer to home, same level of care, but more accessible.
Yeah, SVMC is definitely, you know, for the audience out there, SVMC is in a growth phase for the next several years. We've got oncology is sort of the prime one where we're doing our best. It's going to take time, and everyone needs to be patient, but we're going to expand. We're going to expand our abilities to take on more patients. The same is true in other specialties, including cardiology, orthopedics, surgery, you know, OBGYN, and cancer is really going to help lead that way with construction of a new site. But it takes time. It takes time to recruit in oncologists. It takes time to recruit in oncologic nurses, and we're working hard to do that. Matt, in the last few minutes here, just back to some of the stuff you've been doing at SVMC. You kind of focused on early, maybe several years ago, on treatment of brain cancer and how we could be doing that a little bit different or a little bit more advanced. Just tell me briefly about what you did.
Yeah, so actually that sort of falls into 2 categories, I guess. The most common brain cancers that we see actually didn't start in the brain. They started in other places like the lungs or breast or wherever, and then spread to the brain. And traditionally, because of of the principle of the blood-brain barrier. A lot of drugs and things that are in our blood don't cross into the tissue of the brain very well. That's a good thing. There's a lot of stuff in our blood that we don't want in our brain, but it makes it difficult to deliver drug therapy like chemotherapy when cancer gets into the brain. And so traditionally the treatment has been to irradiate the brain. That can cause problems though too, particularly with memory and thinking function. And so a technique that we've picked up since the new linear accelerator came in is a type of treatment called hippocampal sparing brain radiation, where we carve out, if you will, the hippocampi, the two structures in the brain that are principally responsible for forming new memories. And we've seen that by purposely underdosing that area, as long as we don't see any cancer there, patients can better preserve their memory and thinking function. So that's something that's just taking off all over the place. The other thing that we just started in the last couple of years is for tumors that did start right in the brain, a particularly bad type of brain cancer called glioblastoma. And it's not radiation at all. It uses electric field generation by sort of these stickers. They're like EKG leads that the patient sticks right on their head. They have to shave their head and wear these EKG leads on their head. And this electric field actually inhibits the replication of cancer cells. And since it doesn't use ionizing radiation, basically there are very, very few side effects. Really, the only one that most people notice is that the sticker adhesive itself sometimes causes a rash. It has been shown to really, really control these brain tumors much better for longer. The big downside is the patient has to carry a battery pack around and wear it for about 18 hours a day. But like I said, it's appearing to more than double the survivorship in some of these brain tumors, and starting to be tested in other forms of cancer as well besides brain tumors.
Yeah, that's fascinating. And of course, when I first learned those details years ago, I recognized this is a big thing for our area and keeping patients here locally. So thank you for your efforts. And I know you had you had help, but thank you for that effort. As we close, you're an adventurer, you're a road racer, you got into running. Just tell us a little bit of the history on your running life.
Oh, it's actually pretty recent. I mean, and it sort of started with the job here, honestly. The very first year I got here, the cancer center and the hospital in general was promoting a 5K in association with the Komen Foundation, the Race for the Cure. And so I signed up for this 5K, and the following year I thought, I could probably do the 10K. And so I started training a little bit and running for the 10K. And as I got kind of used to longer runs, I decided to just keep training and do the Maple Leaf Half Marathon later in the season, and just kind of caught the bug. I met my current wife. We found that we enjoyed running races together, and set out that following year to run a half marathon every month for a year, and basically have just continued to expand on to bigger things, marathons and trail races, and later this year we'll be doing our first ultra marathon. So it's just a fun way to get out there and keep moving and see new places.
That is great. We're going to check back in with you after that ultra marathon. Your enthusiasm for running, I hope, radiates out in the community and gets others involved. I'd like to thank you, Matt, for joining us today on the show.
A pleasure. Anytime.
I'll also thank Mike Cutler from CAT TV, Ray Smith from Southwestern Vermont Healthcare, Ashley Jowett from Southwestern Vermont Healthcare. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we will see you next week.